Good afternoon. This is Mrs. Terry, and we're talking about Chapter 8 here in Pharmacology, which is Unit 6, Anti-Infectives, Antibacterial Drugs. You need to there's a lot of chapters here in this unit, so we'll go through as best we can. Anti-infectives, antibacterials, you know what an infection is. It's an invasion by a microorganism that disturbs the normal environment of the body. The bacteria is usually the common cause of the disease or septic and death worldwide, which is what we're going through now with this pandemic. Viruses, fungi, protozoa, other microorganisms cause infection. When a bacteria causes harm, it's called pathogenic. A non-pathogenic bacteria exist with us, so we have bacteria that coexist all the time with us and that don't cause any disease. Normal flora or non-pathogenic bacteria that live in our system, so we don't want to kill out all the bacteria in our system. Opportunistic bacteria cause disease and tissue damage in someone whose immune system is not working well. And that is in your first beginning of the chapter when it talks about opportunistic bacteria. We also talk about virulence, and that's how strong it is, how much it can invade and spread. Bacteria are classified according to whether they can change the color when a dye is put on them. So it's called a gram stain is applied. And those that change color are called gram positive. Those that do not change color are called gram negative. And that's how the doctor determines what type of bacteria it is. In general, gram negative or more virulent and harder to kill. Because they're surrounded by a protective capsule, and thus they don't take up the dye. So they remain unstained. And so they're gram negative because they do not change color. Pathogens, like I said, we have normal flora throughout our body, and that's one reason that the physicians are careful about ordering antibiotics, because you don't want to kill off all of our bacteria. Bacteria also have surface proteins, and you'll learn about that later when we talk about the classifications of antibiotics. And these proteins disguise the type of bacteria. They have enzymes that puncture holes in human cell walls, and they're classified anaerobic or aerobic, which is with and without oxygen. And they're classified according to their shape. Bactericidal and bacteriostatic drugs. Bactericidal kills the bacteria directly, and bacteriostatic stops or inhibits or retards the growth. And I used to work with infection control nurse at the hospital, and we were always talking about what type of chemicals we were going to buy to clean our instruments and to clean the hospital. And we had to know if we needed bactericidal or bacteriostatic. We had to make sure we got the right kind. If a person's immune system is not working well, he would benefit from a bactericidal. In other words, that he needs something that kills the bacteria directly, not a bacteriostatic, which would inhibit it, because his immune system is not working very well. The goal is to kill, of course, the bacteria without hurting the patient. The spectrum of efficacy is a measure of how many different types of bacteria the drug can kill or prevent from growing. So the spectrum of their effectiveness. Each drug is judged by how many bacteria it is susceptible to. And susceptible organisms are bacteria or other organisms suppressed by it. So how many it can injure. A narrow spectrum antibacterial drug can only affect a few bacteria. Wide spectrum or extended spectrum, broad spectrum, they're effective against a wide range. Cultures, each infection has to be evaluated to determine which organism and which med is most effective with it, and a physician will order a culture and sensitivity test. And the labs are always drawn before, if possible, unless it's an emergency, drawn before the first dose is given. So the nurse needs to know, okay, this is the first dose of an antibiotic, and you need to check to see if the doctor ordered a CNS, and if so, has it been done? And it takes usually 72 hours for it to grow in the lab, and cultures can be taken from many parts of the body. General issues with antibacterial therapy: do not quit taking the medicine when symptoms are relieved. Take it all. Take it when the doctor ordered it. Take it for the exact number of days. Notify the doctor if the patient is not improving. You want to look to see if there's a reduction in fever, if their WBCs are normalizing, if there's no drainage or redness still to the area. Generally, you take these on an empty stomach or one hour before or 2 hours after meals. Shake up the oral suspensions, of course. If you start getting hives or itching, stop taking the med and notify your doctor. Call 911 if you're having breathing difficulty. Report if any of these side effects, bloody stools, cramping, low-grade fever, because you can have C. diff, which we're going to talk about later. Pseudomonas colitis, which is what C. diff causes, and it's a deterioration of the intestines, causes necrosis of the intestines. You can get thrush and yeast infection or anaphylaxis, and anaphylaxis, of course, is an adverse effect the patient can die of. Common side effects: diarrhea, yeast infections, because the antibiotic kills off the normal flora that controls yeast. So we usually tell them to eat yogurt or take one of these pills. Monitor for the effectiveness. We've already talked about that. And monitor the IV site for redness. Always ask the patient if they're allergic to any meds, especially if they're any of these antibiotics. Check about the culture and sensitivity. If you're giving these meds IV, you check the patient after 15 minutes for these signs and symptoms. If it's IM, you check them within 30 minutes for sure. There are 4 classes of antibacterial drugs, and those are in your textbook, and you need to know those. One thing I wanted to talk about was on page 117, anaphylaxis and signs and symptoms of an anaphylactic reaction, of course, and all of that has to do with hives, swelling around the mouth. Be sure and read that in the memory jogger, and also read this about C. diff there on that same page. And then the classification of drugs are in Table 8.1. There are 4 classes: cell wall synthesis inhibitors. Those are your penicillins, etc. Protein synthesis inhibitors, metabolism inhibitors, and DNA synthesis inhibitors. So penicillins, cephalosporins, and other cell wall synthesis inhibitors, that's the first category. As you know, penicillin was the first antibacterial drug that was developed, and it was a natural product from bread mold. And these inhibitors prevent the bacteria from forming a protective cell wall. So you remember we said that bacteria have a wall or a coating or something that protects them. That's how they can get strong. Well, this category of meds prevents that bacteria from forming that protective cell wall. And that's how you can destroy them. They're effective against bacteria that divide rapidly and are usually found in skin, mucous membranes, the respiratory tract, ear, bone, and blood. Such infections like strep, tonsillitis, otitis media, UTI, and wound infections. So penicillins are the oldest and safest, and cephalosporins, monobactams, and carbapenems are powerful drugs used only given by injection with serious side effects. Vancomycin is a very powerful drug that's only given by injection, and that's listed on page 118 under the other category. So if you're given vancomycin, your patient is very, very sick. Doctors will hold that off till they have tried everything else. And you now have drug generations. So when penicillin started, that was the first generation, and then as the years have gone on, they will refine, if not for a better word, these meds, and they'll come out with a second generation of them or a third generation of them. So patients may have been allergic in the beginning to one of these, but a second or a third generation med they might not be allergic to. This is a list of common penicillins. Be sure you know those. So cephalosporins are, if a person is allergic to a previous allergy to penicillin, he's highly to be allergic to cephalosporins, because remember, that's from the same category. That's from these cell wall synthesis inhibitors. So you would need to monitor the doctor. And this is what I was talking about, first, second, and third generation of drugs. And all of the generics of the cephalosporin start with CEF or CEPH, as you see here. Then you have other categories, Primaxin, vancomycin. We talked about that. Vancomycin is the last resort drug. It's used for multiple resistant strains of bacteria. In other words, methicillin resistant staph aureus. So those is a strain of bacteria that is methicillin resistant. So no methicillins will touch it, and it's a killer of an infection if you get it. It has a very narrow therapeutic range, and you have to draw a peak and trough, and we'll talk about that here in just a little bit. Here's the values for a peak. It needs to be less than 25, and the trough needs to be 5 to 10. Vancomycin is very toxic to the kidneys. You have to give it very slow. Rapid infusion can cause red man syndrome, severe hypotension, flushing of the face, etc. You have to watch for signs and symptoms of a reaction. It can cause, the carbapenems can cause confusion, seizures, hurt the kidneys, and we talked about the red man syndrome. Protein synthesis, that's a large class of antibacterial drugs, and it slows protein synthesis. So the bacteria needs protein, and these drugs disrupt their life cycles because they can't get the proteins that they need. So they prevent bacteria protein synthesis, and these are aminoglycosides, macrolides, tetracyclines, streptomycin, very, very prominent one. Glycosides, they usually end in CIN, so the mycins, or mycins, or the gentamicin, tobramycin, neomycin, streptomycin, very common ones. They can injure the ears and the kidneys, cause muscle weakness, respiratory depression. They're commonly used for burns, meningitis, joint and bone infections, intra-abdominal infections, peritonitis, and sepsis. And so you see that this is a stronger bacteria that they're trying to fight. Sepsis is a infection throughout the entire body. So that's when the doctors will start ordering gentamicin, tobramycin, etc. You need to watch the blood levels because they have a very narrow therapeutic range. And that's what I talked about, the peak and trough. The peak is drawn 30 minutes after the infusion, and the trough is drawn right before the next dose. So you will call the lab and you tell them you need a peak and trough drawn, and you're getting ready to administer that drug. And then 30 minutes after it is given, then the lab will come up and draw a peak. And then right before the next dose, they'll come in and draw a trough. So you make sure that if that's ordered, that has been done while you're on the shift, so that you don't mess up the timing of that and give that drug at the wrong time. Macrolides are extended to broad spectrum effects, and they usually end in OMYCIN. So erythromycin, azithromycin, clarithromycin. Erythromycin can really make you sick, so you've got to take it with or after food. You have to run it slow. Photosensitivity, and you'll see a lot of these patients are very photosensitive, light sensitive. We use these for skin and wound infections, middle ears, lower respiratory tract, genital tract infections. And they interfere with a lot of drugs, DIG, Coumadin, etc. Tetracyclines, that's a broad spectrum, and it ends in cycline, and you can see the side effects, what it's used for. Tetracyclines are only given to patients with a very healthy immune system. They can cause tooth discoloration and tooth and bone development in patients who are pregnant or less than 8 years old, and we don't give them to children less than 8. Avoid dairy products, antacids, and food. Outdated med may cause nephrotoxicity, so we sure don't want to give it an outdated med. Take the oral form with a full glass of water. Avoid sunlight, and can cause intracranial pressure. Tetracyclines you have to really watch any of these. Clindamycin is Cleocin. It can cause shock and cardiac arrest. Zyvox can cause optic nerve, and we use these for MRSA. Zyvox is used for that. Another category is metabolism inhibitors. Prevents bacteria from making folic acid. Sulfonamides, Ciptra and Bactrim, used for urinary tract infections most often. Also used for non-bacterial infections. Can cause anemia and decrease in white blood cells, so we have to watch their bone marrow suppression. Check for sulfa allergies. So sulfonamides, that'll help you remember it. Ciptrum and Bactrim, you got to watch sulfa allergies. Adverse effects, Stevens-Johnson syndrome, which we have already studied, and can cause non-infectious hepatitis. You must be well hydrated and drink at least 3 liters of fluid a day, which is a lot of fluid. Watch if your patients are taking a thiazide, and watch sun. Another category is DNA synthesis inhibitors, and 4-quinolones is the med used for respiratory, GI, GU, and some skin infections. Excreted primarily by the kidneys, end in OXACIN, so Cipro, ciprofloxacin. You hear Cipro a lot. And it's used also for anthrax, Cipro is. GI, headache, rash, nightmares, increased pressure in the brain, neuropathy, tendon rupture, a lot of side effects to those meds. Patient teaching for 4-quinolones. Give with water, avoid iron, avoid antacids, monitor the heart, photosensitivity, joint swelling, and watch for big time effects. Multi-drug resistant organisms. There are many organisms that are resistant to multi-drugs, and they have become immune. These bacteria have become immune to meds, so there's very few meds that will touch them. And one is what we call MRSA, MRSA, methicillin-resistant Staphylococcus aureus. And MRSA is very, very, very dangerous, and started when I was nursing on the floor, and you never heard of a MRSA patient, and then we had one, and our infection control nurse was so upset. And over the years now, I've seen, well, MRSA is just, I don't know, it's kind of common in the hospitals and long-term care, and it's sad. And they have to be in isolation, and the things you have to do, and that's why it's so important for nurses to not pass bacteria on to the next patient. You've got to wash your hands. You've got to keep your clothes clean, your shoes clean. You've got to keep the Foley bag up off the floor, and because you can pass one of these deadly organisms to a patient, and if they're fragile already, then they may not live. VRE is another one. It's intestinal vancomycin resistance. It's resistant to vancomycin. This is resistant to methicillin, and there's just very few meds that we can give them to help them. And the use of antibiotics created these resistant, and then they spread through community acquired now or hospital acquired. The patient goes in, they go in for another reason, and they come out with MRSA or VRE. Sad. Chapter 9 is anti-infectives, antiviral drugs. Make sure you know all of the terms and categories. Understand tetracycline can raise intracranial pressure. Aminoglycosides, know the side effects to aminoglycosides. You know that tetracyclines can cause tooth development problems in early childhood, discoloration of teeth. You know Stevens-Johnson syndrome. Know what jaundice is. Know what to do before giving sulfonamines. Check the patient's skin for bruises. Give it with a full glass of water. Read all of that on page 131. Know the common side effects of fluoroquinolones. Muscle and joint pain. They can actually rupture a tendon. A rare effect of fluoroquinolones is a rupture of a tendon in the arm. Unbelievable. Peripheral neuropathy can mess up the hyperglycemia, hypoglycemia, nausea, headache, rash, but that muscle and joint pain is fluoroquinolones important. And then the antibiotic-resistant drugs, why it's from overuse, prescribed for conditions not responsive, and or drugs are taken improperly. They cause drug-resistant strains of bacteria, so you get antibiotic-resistant strains, and very, very dangerous. Make sure you know the key points on Chapter 8. Moving on to Chapter 9, antiviral. You need to make sure you know the key terms in the front. A host is the person infected by the virus whose cells allow viral reproduction. So viruses infect a living host, and which is what we're dealing with now with COVID. I'm going to stop at this point and get this posted and start on another video. Thank you.